start with a broad welcome with Talofa, Bula, Ni Hao, Namaste, Bonjour, Guten Tag, or hello to you all. My name's Paul, and I'm your Look Good, Feel Better facilitator for today. So with that, I'm going to introduce Victoria, and it's wonderful to have you, Victoria. So Victoria is an experienced registered nurse and a nurse support coordinator at Bowel Cancer New Zealand. She's going to provide an overview about bowel cancer, the symptoms, the diagnosis, the treatment options, and the support available for patients and for their family. So Victoria supports families and individuals through bowel cancer through New Zealand's confidential nurse support service, offering education and guidance and a listening ear. So if you've been diagnosed with bowel cancer, or someone you love has been diagnosed, don't be afraid to reach out to her. She says, I'm here to help. And with that wonderful help, thank you, Victoria. It's wonderful to have you with us tonight. So the floor is yours, so to speak.
Thank you so much. Kia ora koutou. Lovely introduction. Thank you. Yes, I am Victoria. I am the nurse support coordinator that is with the charity Bowel Cancer New Zealand. So being another charity, it is always an absolute honour and a pleasure to be invited into Look Good, Feel Better to do a presentation and to just have a chat, which is kind of what this is. So please do, if you do have a question that's burning partway through, you're more than welcome to ask. I'm more than happy to wander off down a little rabbit hole and I will probably take myself down a couple from time to time anyway. So please do feel free to ask questions. I do have a bit of a presentation that we'll just kind of work through. It is a little bit of kind of bowel cancer 101, and there are some interesting updates, which hopefully some of you will have heard about recently. So this is us, Bowel Cancer New Zealand. A few of the unfortunately, shockingly terrible statistics that we carry within Aotearoa New Zealand. There's around about 3,300 to 3,400 people diagnosed with bowel cancer every year. Now, around about 1,300 die from bowel cancer every year. Putting that into perspective, the number of deaths from bowel cancer are around about the same number that you would get from breast and prostate combined. So it's pretty big. It makes it New Zealand's second deadliest cancer. So there is a lot of work still to be done. The unfortunate thing also with bowel cancer is that it's becoming increasingly more so within our younger population, so those 50 years and under. Māori and Pacifica tend to be diagnosed also much younger and often at a much later stage. Men are slightly higher in their diagnosis rates than women, but it is slightly higher. That generally is a pretty even playing field. And amongst all of that, the absolutely outstanding news is that it caught early, it's well over 90% curable. So it's beatable and treatable when it's caught in those early phases and stages. Just really, really quickly running through, because what we're finding is that it's really important for people to know what to look for. So bleeding. Bleeding from your bottom is not normal. Now, it could be from a whole lot of different sources. That includes things like hemorrhoids, if you've been constipated or had major diarrhea. It can also be from benign polyps that may be in the bowel wall that have started to bleed. So not all bleeding is going to be bowel cancer, but you should get it checked out. The other big thing to be looking for is changes to what's normal for you. Now, that could be things like how frequently you go. Is it more or is it less? What does it look like? Is it thinner? Is it smushier? Is it a different colour? Does it smell different? Have you got more gas? And is that gas something that would put the dog to shame? Those kind of changes need to be taken into account, and you need to keep an eye on them so that if they're going on for more than a couple of weeks, it's a conversation that's worth having with your GP or with your doctor, with your healthcare provider, or whoever it is that's your primary port of call for your health needs. The other things to look for are those really severe pains that we can have in our tummy from time to time. If you happen to notice a feeling of a lump that's down around that bottom end of your tummy, and then tiredness and weight loss for no apparent reason. So those are the kind of pictures that we're looking for. The unfortunate thing sometimes is, though, that a lot of people don't have symptoms prior to being diagnosed. So it is a disease that can kind of sneak up on people, and it's not until things are very acute that it becomes, you're aware that it's actually there. However, do keep an eye on things. And I always say to people, if you've got a gut feeling, yes, I know this presentation will be full of terrible puns and dad jokes, probably. If you do have a gut feeling that something's not right, go and have a chat with your doctor. Nobody has of yet, in my experience, and I've been nursing since Adam was well before a cowboy, nobody's died of embarrassment. So let's not die of diseases which are actually really beatable and treatable. So some of the risk factors that are involved with bowel cancer, some things we can do something about, some things we can't. Our age, for example. I am the age I am, and I can't do anything about that, regardless of the fact that sometimes my brain thinks I'm in my 20s and my body thinks I'm in my 90s. The fact is, I sit in between both of those numbers. So your risk does tend to increase as you get a little bit older. Genetics, there's again not much we can do about our genetic makeup. Our mum and dad are our mum and dad, our grandparents are our grandparents, and our aunts and uncles are all involved with all of that as well. There are some genetic conditions which predispose people to certain forms of bowel cancer. Things like Lynch syndrome is quite well known about. That's where you have a mismatch in some of the genes that are sort of floating around your body. And then there's a whole lot of multi-polyp syndromes, which have really, really cool names that you can see on the screen there. And I'm not even going to bother trying to pronounce them at this time of the evening. There's other things that can increase your risks as well. If you've got a history of any of those inflammatory bowel diseases, so things like diverticulitis, ulcerative colitis, Crohn's disease, irritable bowel syndrome, all of those kinds of diseases where your bowels are already really irritated and really upset with you from time to time can increase your risk. Again, not a lot you can do about those, but for most people, there's a pattern to their flare-ups of symptoms for these particular diseases. So again, it comes back to knowing what's your normal sort of pattern around that so that you know if it's not normal. And then there's stuff that we can do things about, what we eat, what we drink, how much we move, and those kind of things. We can kind of make some changes to what our diet looks like. We can increase our exercise. Stress is one of those, yes, we can, no, we can't. When you're working 70 hours a week and you've still got 3 kids, plus you've got your mum and dad living at home, sometimes our stress levels can't really be modified too much, but there's still stuff that we can do within that. There's some other things that you may have heard in the news recently, which would include things like nitrates and microplastics, and a whole lot of other things that we're just starting to learn a lot more about within research and science, and all of those really smart people that have lots of letters after their name are looking into it. I think one of the things to remember is that with a lot of these things is that there's still a lot of research that needs to happen. And just because something is there doesn't mean it causes it. So, for example, microplastics, says me with a plastic bottle of water sitting beside me. We all have, to an extent, an amount of microplastics in our gut, but not all of us are going to get bowel cancer. So just because they're there doesn't necessarily mean we're going to get it, but they might increase our risk. So that's just a little bit of an explanation about some of the things that we're hearing more and more about out there. We do have a national bowel screening program within New Zealand. Woohoo! It's really cool. It's really simple. It's really easy. It gets sent out every 2 years. And as of today, this very day, it has come down in age from 60 to 58. However, it's only Auckland, Northland, and the South Island at the moment. And in March next year, the rest of Aotearoa will come on board with that. So, like I say, as of today, it has come down to 58 for everybody, all the way through until 74. I am going to talk about what you can do if you sit outside of those screening ages, so just hold on for one moment. I have popped in there the telephone number for Time to Screen, who hold that government screening program, and you're welcome to give them a call if you're concerned about where a kit might be and when it might be next due to be sent out to you. So please do give them a call. And again, it comes down to, if you forget everything, get hold of me somehow, and I will forward all of the information on to you. So, like I say, I do have some information about screening if you sit outside of those age groups. And there's 2 recommended kits at the moment that you can purchase. They do look expensive, and the Allevia Radiology one has unfortunately just gone up as of last week as well. So the 2 kits that are available, one is from a company called iGens, that's there to detect specific DNA from bowel cancer tumours in the bowel. So it's very specific. The Allevia Radiology is very similar to the kit that is sent out via the National Bowel Screening Program, in that it's looking for blood. While it cannot tell you where the blood is coming from or from what, it can tell you that it's there. There's information about all of these things on our website, and I've got details about our website towards the end. So do just keep in mind that even if you sit outside of those bowel screening ages, there are some tests that you can actually purchase that will at least allow you to continue with some screening. So we often talk about stages with any sort of cancer, whether that be breast, prostate, melanomas, lung, whatever type of cancer we're actually talking about. We talk about different stages, and we do the same thing with bowel cancer. The earlier the stage, so the lesser the number, the closer it is to 1, the better the prognosis and the better your outcomes are going to be. The further up it gets, the bigger the number, tends to be slightly worsening prognosis, or it's not looking quite so good for you. That being said, again, stage 4 isn't the if you'll excuse the terminology, death sentence that it used to be. It is much more people are actually living well, even though they've had quite an advanced diagnosis. So this is just to give you a bit of an idea of what we're talking about as far as bowel cancer goes. For the most part, when it spreads, it will generally speaking go to either the lungs or the liver are the 2 main ports of call. And so, that can impact things like your breathing, and it can impact, your tiredness and things like that, depending on where it's spread and how much it has actually spread. So those are the stages. Now, I'm hoping that those of you who may have just had your dinner or about to have your dinner aren't squeamish. There's just a couple of pictures coming up next. I'm just warning you, just in case you can look away if, pictures aren't your thing. So these are some images of what the polyps look like when they're growing in your bowel. Now, it's polyps that left untreated can potentially become a bowel cancer. So the ones there that look a little bit like mushrooms or toadstools or weird kind of things, UFOs, growing up there, they've got the best name on the planet. They're called pedunculated polyps. Best word ever. Put that into a sentence at some point tomorrow, I dare you. And these ones can get quite big. They can actually become, a couple of centimeters in length. And so you can imagine that as everything's kind of passing through on a regular daily basis, they can cause quite a few problems. They can also be quite small. So sort of from about like a grain of sand upwards. And the other one that's there that's just kind of down just above our logo there is what's called a sessile polyp. These ones are much flatter to the surface of the bowel. They can be much more difficult to detect, particularly during a colonoscopy, because they can be quite flat. They're a little bit like, if any of you remember the days where you had pimples. They're a little bit like that, in that they're just kind of these raised areas that sit within the bowel. Again, it's only a certain type of polyp that can become a bowel tumor. However, the bigger the polyp, the more likely it is to potentially turn. And in the next slide, we actually have a picture of a bowel cancer tumor. Again, you can see that it's quite large, quite sizable, and it's actually taking up a really big portion of the circumference inside the actual bowel. So you can imagine the changes that would occur to anything coming out if you've got something like that growing in your bowel. It can also cause things to back up quite markedly behind it, causing acute pain and obstructions. This is what we don't want to see. So that's what they can look like, just for those of you that are visual. I quite like pictures. They make my life better. So your treatment will obviously depend on what stage your bowel cancer is found at. So if it's found nice and early, generally speaking, it is surgery. They take the tumour out, they check the margins. Once you're clear, you're clear. Stage 2 will often involve, depending on where it is, surgery, radiation. The lower down in the bowel it is, the lower it is towards the rectum or the anus, the more likely you are to have radiation prior to surgery. And sometimes it is a little bit of a mixture of those two things. Chemotherapy can come in with a stage 2 if they've done the surgery, but they're a little bit concerned that some of the cells might have escaped and that they haven't got clear margins, or those really clear defined spaces where there's actually no tumor marker cells on those. Stage 3 will generally always be a combination, generally surgery and chemotherapy. Again, it will depend on whereabouts in the bowel the tumor is as to how you might have that. You might have radiation and chemotherapy together and then have surgery. You might have surgery and then radiation and then chemotherapy. That's a conversation that people that are paid a lot more than me get to have with you when they do those initial assessments with you. And stage 4 will always depend on where it's spread to. So it will always be a combination, plus or minus some of the targeted therapies, which are reasonably new for New Zealand to be involved with. And then sometimes you'll hear people talk about palliative. This is where the tumours have spread so widely that most of the treatment that you will have will be around symptom management. And it can still involve things like palliative chemotherapy, palliative radiation, and all of those kind of things. So again, depends a little bit on what they find at any given time as to what your treatment will look like. A quick note about surgery, because we have a lot of questions that come through about why aren't my bowels, why won't they go back to normal, quote unquote. And I'm hoping that this gives you a little bit of an idea about why things might be quite markedly different after you've had bowel surgery. The bigger the chunk of bowel that they take out, the less transition time there is. So a fully functioning bowel, as we all know, things from eating until they pass through the other end is, give or take on average, somewhere between 20 and 26 hours. That's normal time for it to pass all the way through. So you can imagine the last phase of that is what's done in the bowel, where the last of the water's taken out and where the rest of the waste products kind of get all smushed and pushed into place. So the more you have of that taken out, the less that transition time is, which can mean things like much looser bowels, more slightly prone to kind of diarrhea and things like that, and it will often come in bouts. If you are losing things like your rectum, or a good chunk of it, the rectum is the holding bay, if you'd like to think of it like that. It's kind of where everything gets held and it will send signals to your brain going, hello, it's time to go. But if you're not in a safe place to go, your rectum will also hold on long enough with its sphincters so that you can actually get to a toilet in time. We've all had those occasions where we're out and we go, no, I'm not going to use this bathroom here. No, I don't like this one. And so you hang on until you get home. If you lose your rectum in any part of those sphincters, you lose that control and you don't always regain that. So hopefully this gives you a little bit of a visual kind of an idea so that you can see that, if you have a big chunk taken out, or you have some of these really specific kind of holders and sphincters which actually keep things closed, why things will be quite different. And you can imagine if you've taken the whole lot out due to a number of different reasons, you may lose your entire bowel. People will be left with a permanent stoma. If you've got questions about stomas, I'm happy to answer some of them where I can a little bit later. So we do have a number of therapies. Some of these people may have heard some of the terms. Some of them may be quite new. So you've got Folfox, which is a combination. You've got Folfuri, which is a similar but different combination. I can't pronounce all the drug names. I'm really sorry. They've got really weird names. Like, seriously, who comes up with these things? And then there's a whole lot of versions within that. We also have some that you can have alone. 5FU is kind of the benchmark as far as chemotherapy for a lot of adults having bowel cancer chemo. Same with capecitabine. And then the new ones that have come into the system over the last sort of 12 months or so have been, again, pembrolizumab. Isn't Keytruda so much easier to say? I think so, and spell. So pembrolizumab is generally used for Lynch syndrome. That's that mismatch repair, mismatched genes. And cetuximab, which is used for a specific side tumor, which has got none of the mutations in it. So those are the two new drugs that have been funded in the last little bit. We do have some others that we would still love to see a bit more available in New Zealand, which tend to be sort of standard of care in other places. Again, they've got names like, come on. Avastin's so much easier to say. Encorafenib is the other ones that are down there as well. So these ones can be used and they are available. They've been MedSafe approved. However, they cost. And that's a cost to the patient and their whānau be able to pay for that. And it's not just the drug. It's actually the administration of the drug within a private hospital setting. So it's a bit of a double whammy. Who are we? Well, we're a charity that was set up in 2010. And it just occurred to me the other day, that's 15 years ago. My gosh. And it was set up by patients and their whānau, realising that there was kind of a bit of a hole out there where bowel cancer patients didn't have, kind of community support. And so they kind of worked together to get this charity off the ground. We're here for not only patients and families and patients and communities, but that whole wider spectrum. We want to be making sure that people are aware of bowel cancer, what to look for, what's out there, and all of those kind of things. I do a lot of work around education And we also work within that advocacy space, and we will keep banging the drum about having age extensions for the screening program until they're listened to. And we will keep advocating for better medications, which are, like I said, a bit more standard of care throughout the rest of the developed world. So there's a lot of bits and pieces that we do within our scope, and within kind of what I do. I have a finger in all of those pretty much, except maybe fundraising. Although, every now and then. I play lotto every now and then, which I figure maybe pays towards something occasionally. So that's fundraising, surely. That's my theory anyway. So as a charity, we don't get any government funding. We rely on the support of our communities. Yeah. And there's plenty of ways that people can help us in the work that we do. Now, while we sound like a really big organisation, this is us. This is all of us currently as we stand. Next week, drum roll please, we have a new member of our team starting. So we have a new social communications and marketing person coming on board next week. And currently I am interviewing for nurses to come and join me. The role has got so big that I can't do it on my own anymore. So we are actually getting nurses in to give me a hand and do more of this and reach more people and be much more available. So the team is growing, but today there's 6 of us, and that's it. We're about half full-time, part-time, and so yeah, we cover the length and breadth of New Zealand, slightly on the smell of an oily rag, as do a lot of other charities and not-for-profits. If you ever want to get hold of me, if you forget absolutely everything I've said, that is absolutely perfectly fine, because on our website, there's a little chat function. So if you go to bowelcancernz.org.nz, there's a little chat that will pop up on every single page that you visit, and that comes to me. And I will answer it. And I answer all of those questions individually as they come through. I don't do it at 3 a.m. Sorry. I'm in bed, asleep, probably with my dog at my feet and my cat trying to scamper around my pillow. So during my hours, I will get back to you as quickly as humanly possible. And if you happen to message me out of hours, you will get an email back from me with the answers to your questions. That all being said, is there any questions anyone has that I may not have covered? I do have a couple that have been sent in, which I'm happy to, I will get to answer as well. So the first one that I had come through was around some of the effects that can happen if bowel cancer progresses. I touched on this really briefly, and it depends a little bit where the bowel cancer has progressed to or metastasized to. So, for example, if it's gone to the lungs, you may find that people become more short of breath. They run out of breath much more quickly. And it will depend a little bit on the size of the tumours which are within the lungs and kind of where they're impacting the most. So that can be one of the things. And sometimes for some people, that's one of the first signs that they have. They get quite short of breath. And it's not just from having low iron levels, it's actually from having tumours in their lungs. If it goes to the liver, which is the other most common place that it goes to, one, you can end up with a very slightly yellowing of your skin, and that will get worse as liver disease worsens. But it can also have things like it will change the colour of your urine, it will make you more tired, it can make you a little bit forgetful around the edges, but it has to be reasonably advanced for that. But sometimes you can just feel like an area kind of, I'll just stand up slightly, just slightly under your diaphragm in here, can actually feel a little bit like it's pressing in on things as well if there's a little bit of inflammation there. The other place that it can go to, of course, is within that peritoneum. again, excuse me, that's kind of down round through here in that pelvic space. And if it's gone through there, you can end up with things like fluid building up in that area. It can be quite painful and uncomfortable to have the disease when it's spread down through there, because it can press on things like your bladder and your bowel and all of those other things for us women on our uterus and things like that. So it can become quite uncomfortable depending on what's going on. So again, it does depend where it has spread to and how badly it has spread, as to what that might look like.
Victoria, just with that one, I know a friend of mine, he ended up with some tumors coming in his lungs as well, but then he started getting a lot of, and I put a question in there around fluid in the legs and things like that. Is that fluid in the legs a sign of anything in particular, or is it just a kind of like a
It often means that your lymph nodes aren't working properly. And so for a lot of people, you can have quite a number of lymph nodes taken out and it really doesn't make any difference at all. For some of us, that when we have our lymph nodes taken out when they're doing surgery and things like that, it can preempt a little bit of that fluid accumulating.
Right.
Often when the fluid starts to accumulate, particularly in the legs, it's the lymph nodes in your groin that are most impacted. And it just means that they can't filter as quickly because the lymph uses your blood system to kind of pump itself back. And so, yeah, sometimes really gentle exercise can help, moving your legs and your feet quite regularly just to kind of keep everything flowing back upwards, keeping them elevated and things like that can help too.
You were talking about the polyps there in some of your pictures, and that one particular one, that very small one. And I just made a note in there. I guess this is why they're so insistent on the lots of flushing of water and so forth, right, to really clear it out. Do most people successfully clean themselves out well? I mean, is there a lot of failure in that process for colonoscopies where people don't kind of flush enough or things are missed?
Yes, you do. The cleaner the bowel, the better the outcome.
Right.
It kind of is almost as simple as that. The joy of having a colonoscopy is more the prep than the actual procedure, because having to drink that amount of fluid until everything runs clear is mind-blowing and really just not all that pleasant. And so some people will give up a little bit early. Unfortunately, if you don't clean out properly, procedure has to be abandoned, and then you have to do it all over again, come back. And if it was me, I'd rather be a once and done girl. I'd rather do it properly. But yeah, the cleaner the bowel, the more likely you are to be able to see those really, really small polyps, those sessile ones that are really small and flat. Sometimes the light doesn't bounce off them quite so well, particularly if they're in a little, dip within the bowel. They can be quite difficult to see.
So they're ones that will become cancerous potentially?
They can do. That's the thing. I mean, polyps are basically just a little bit like a skin overgrowth. I don't know if anyone's got skin tags or knows what skin tags are. They're just like a little overgrowth of skin that kind of comes out. Some of us women, we joyfully get them in and around where our bras sit. It's a great thing. But so, they can kind of be a little bit like that. So the more they're irritated, the bigger they can get. The more irritated they are, the more chance they have of kind of turning a bit nasty.
We've had another question come up here. I've recently finished chemo for stage 3 bowel cancer. Interested in steps I can take to stop it coming back.
Okay, that's a really good question. There's a lot of things that will help. Along the lines of, diet, exercise, mindfulness. I'm not a huge fan of that word mindfulness. That whole kind of space where you can just kind of get away from things and turn the outside chatter off. I made a huge breakthrough a couple of months ago. I used to have one of those watches that does all your steps and all your messages and things come through to.
Right.
I stopped wearing it. What a game changer. Because it just took out some of that mind chatter that goes on, you know, oh, I've got to look at that, I've got to look at that, this creating this sense of urgency. So taking time out to kind of just settle your mind back down again and just kind of breathe and do those kind of things. Now, just between us, because it's only the few of us that are here, we are, if any of you have heard about some research that came out recently called Challenge, it's to do with very late stage 2 and stage 3 bowel cancer and overall survival rates using a 3-year exercise program, which is quite regimented, for want of a better word. I can't think of the word I want. We're looking at how we might be able to implement that for patients that would fit within that. So whoever's asked that question, keep an eye out for the information. Okay, there you go. Keep an eye out for that information, because we will be looking at that sort of early next year around launching it. So do just keep an eye on our website or on our things, and I'm sure we'll make this enormous song and dance about it when we do look at it. But there's certainly lots and lots of things that you can do around keeping yourself as well as positive as possible, and just kind of allowing yourself time to smell the roses, as it were.
Yeah. It's finding that that space where you can free your mind from the thought of cancer and create that space.
Yeah. And I mean, we all know, anyone that's had any sort of diagnosis, the reality of scanxiety is just overwhelming for some people. You know, that anxiety that can build up before blood tests and scans, and, you know, any sort of procedure that we need to have, that anxiety can build up. It's learning how, you know, you can do some work, you know, around how do I control that a little bit so that I don't freak out and every time I have to go.
So the next question's a really interesting one with regard to help available for my sister, because she's supporting me. Now, I'm going to put a bit of a plug in here. Our next Q&A session is actually called Caring for the Carer. So I'd recommend that you jump on board for the Caring for the Carer one, because you've raised an extremely important point. Just as the person at diagnosis gets a shock, so does the person alongside you. And they're not the ones that really get the support and the help, and it's extremely hard. And often they're the ones sitting there when you're out to it or whatever, and they're doing all the worrying. So Victoria, you may have something within you know, your organisation that have some pointers there for help for the carers as well.
Yeah, you said that so beautifully. I worked in the community for such a long time that the one thing I learnt, that is, if the carers in the whānau fall down, then patients' outcomes can be so much worse. So carers are vital, and yet they get overlooked so often. We do have support available for main carers. I made sure that when we brought counselling in available as one of our services, that was also for that main carer, whoever that main carer actually is, because it's important that they actually get the support and the tools that they need as well. I mean, things like I'm available, I can point people in the right direction of other services like, you know, Look Good, Feel Better, and the platforms that you have out there, as well as, you know, organisations that will help with children who have got a parent that's been diagnosed, and all of those kind of things. So if you are a carer, or you're worried about the person that's caring for you, you know, you are vital within this. Please know that. And if I can support you in any way, then please reach out and I'll do what I can and either point you in the right direction or get some support through to you.
Yeah, and that word counselling, it puts people off, but it's not really counselling. It's an ear. And they can help you reflect on things that you might be able to help yourself with. So don't be afraid to talk. Sharing makes a hang of a difference, and these people are extremely experienced often. In people that are alone or feeling trapped or challenged, you know, carrying burdens on behalf of others. So, you know, please, I recommend highly that you can talk to others.
Yeah. And I think the other thing that goes with that too, sometimes, Paul, is that having someone who's not your main carer or not someone you love that you can rant at or have a bit
Yes.
of a vent at, or just kind of, you know, get some skills is actually really, really helpful. You know, even for myself, I know sometimes you know, having someone who's not really close to me that I can talk to, that I can just go at is hugely important
Yeah.
to kind of for my own well-being as well as, you know, others. So yeah.
So if you have a look in the chat box, Christine's put up there so that's Caring for the Carer is on Sunday the 19th of October at 4 o'clock. And Joanna said, I found a local cancer support group. You know, and that's fantastic too. Go and chat to the people at your local cancer society. They'll often know where the women's or the men's support groups are and their contact details. So yeah.
Absolutely.
Okay, so the next one here, just the variations on bowel cancer and the other people's experience on chemotherapy. So I guess people are seeking if there's any conversation or dialogue amongst us here. But I guess, well, I know that like any of the cancers, it seems that the name of the cancer is the only common thing, is that everyone, you know, they'll say, oh, I got bowel cancer, but people will say, oh, no, this is what I had. And someone else will say, this is what I had, and this is my experience, and this is my age, and all of that. So it's not the same, is it? It's different for everybody, isn't it? Is that what you found here?
Yeah, it is. And we all react to it differently. We all have different experiences with it. The thing with chemotherapy sometimes is that you might sail through the first one, but it's a cumulative effect. And, you know, by the second, third, and fourth round, you're kind of thinking, holy moly, who got the license plate of that truck that just hit me? It can be a really kind of it adds up over time. Unfortunately, some people react really badly, really, really quickly, which is good and bad. In a way, it's good in that then they know not what to give you and they won't do it again. But it's also bad because, you know, there can be some quite bad heart issues that can come out of some of these things. So we all do react really differently to it. Tumors react really differently to dosing and combinations, and depends where it's growing and how old you are and what's going to be effective and what's not going to be effective, and you know, whether it's a genetic one or whether it's a what we call a just one that appears out of nowhere. You know, so many things are variable within chemotherapy that although there might be a lot of, you know, well, this one caused me this and this one caused me that, not everyone's going to be exactly the same, although they might have similarities. You know, the numbness in the fingers from oxyplatin and toes, and that aversion to cold, and all of those things that you get with oxyplatin and things like that can be really similar, but they might sort of show up differently in different people or to different extremes, you know, depending on who you are.
Right. We're up to number 4 now on it's probably one you're better able to answer. So the success rate of reversal from an ileostomy, specifically continence. Have I said that word correctly?
Mostly ileostomy, yes.
Ileostomy, okay.
So ileostomy, colostomy, that's where part of the intestine is brought out onto the surface of the abdomen, and that instead of your poop coming out your butt like it normally would, it would come out this opening that's been made. So they're either temporary or permanent. Sometimes people have a temporary one post-surgery to give the rest of the bowel time to just kind of get its stuff back together again. Oops, nearly put my foot in it. To get themselves back together and to kind of heal and to kind of relax and do all of those things, and then they can rejoin it back together, so you get an anastomosis. Again, depending on how big a chunk of the bowel they've taken out will depend on, you know, the long-term impacts.
Right.
A permanent one would be if you've had pretty much the entire bowel taken out, in which case there's no way that they can rejoin the ends, and so you're left with a permanent either ileostomy or colostomy. Specifically answering this question, I've heard both ends of the spectrum. I've heard people that couldn't wait to get rid of their stoma and their ostomy. They've absolutely fought to have it reversed, and have regretted every single minute of it. It's unpredictable. They don't know when they're going to go to the toilet. They've got what they call clustering, which is where you go and 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 go for a couple of hours. It could be up to 20 times within 2 or 3 hours. And then you have a break for a little bit of time, and then you start again. And it gets to the point where it impacts your life so much that people will often ask, can I please have a stoma back again? So I've heard that end of the spectrum. I've also heard the other end of the spectrum, where people have had their stoma reversed, they've been re-anastomosed or rejoined back up together again. And apart from the fact that things go through a bit more quickly and they have to be prepared to go to the toilet right now, they've actually been okay. And they've actually enjoyed the freedom of slightly more normal way to defecate and get rid of waste products from your body. You know, sometimes the impact of actually having the stoma, particularly for our younger people, you can imagine having a stoma if you're still trying to date, if you're, you know, thinking about having children, you know, all of those kind of things. It could be such a barrier for people that they will go and get the reversal done and kind of put, you know, go with what the consequences of that might be, good or bad. So yeah, specifically, I am going to sit on. I've heard both ends of the spectrum, and it does depend a little bit on how long you've had the stoma for, why it was there, and how much of your bowel has been removed, whether or not you've maintained all of your sphincter control and all of the nerves that control those particular things, and a whole lot of other things that actually come into it. So I've heard both ends.
Right. Yeah, it impact. I think sometimes we underestimate the impact on life for people, and it can be devastating. I mean, you think about an airplane flight, for instance, and you've got to stay seated, you know, and just things like that. It becomes quite limiting, doesn't it?
Yeah, it can do. And just even simple things like a bag full of air, particularly when you're flying with all the different pressures.
Oh my gosh, yes,
you know, you can just kind of imagine going
right
up and down. It can be quite uncomfortable and things like that. So there's a lot of things to take into account, but they can make life incredibly much easier for people when they've lost chunks of bowel and, you know, some of that control. But, you know, some people just need to have them reversed for, you know, kind of their own self.
Is one of the consequences of the bowel cancer a little bit later on, is it weight loss? Do you find that people end up losing a lot of weight, or is that diet-based still, irrespective of you know, a bowel cancer? Or do people end up at various stages eating less and so forth through the chemotherapy or the other treatments? And
There can be some huge nutritional deficits when you've had a big chunk of your bowel taken out, in that you lose a lot of natural flora and fauna. You're more likely to dehydrate quite quickly because that last bit of fluid reabsorption which happens during the bowel doesn't, and so you can dehydrate quite quickly. So you do need to be really careful of making sure that your fluid intake is really good.
Right.
And there can be vitamin deficiencies and things like that, because again, that the bowel is where all the very last of the good is taken out before all the rubbish is kind of got rid of.
Right.
So there can be some nutritional deficits, whether sort of the more likely you are to see sort of big weight losses and things like that would be with much more advanced disease where it's actually spread other places.
Okay.
Or if somebody's got an obstruction and they can't eat for a number of weeks or whatever until that obstruction has cleared or been taken out. That can cause some weight loss and some issues there. Those kind of things can be talked through with your medical team. You can get referrals through to dietitians and nutritionists and things like that to make sure that you have an optimal diet post bowel surgery and things like that.
Right. Yeah, it's complicated, isn't it? That's for sure. I'm pleased there's people like you around that people can ask questions of, that's for sure. Now, we had one more question, but of course it's probably more a medical-based one, and that was with regard to having to stop eating because the pain's so excruciating, and so forth. And where do I go for guidance and support?
First port of call, depending on how bad the pain is, if it's really bad, ED, go to emergency and get that looked into. If it's something that kind of comes and goes and it's quite sporadic and it's quite intermittent, it might be the best place to go would be GP and or to your usual primary healthcare provider, however that actually looks for you, and having a chat with them and letting them know what's actually going on. They're the ones that can do any referrals or any other, or triage what it is that actually needs to happen. Other places that you can look at is always going back to the team that you were under at the hospital. So whether that was an oncology team, a surgical team, or a radiation team, go back to them and have a chat with them. Sometimes the easiest way to get some sort of advice on these sorts of things is to maybe ring your local hospital switchboard and ask to be put through to the colorectal nurse specialists. They're the ones that are going to be able to advise much quicker, probably, and at least alert the appropriate team members who were part of your care while you were going through, your initial treatments and things like that. But if you've stopped eating, got any sort of really bad pain, nausea and vomiting, anything like that, either straight to emergency or make sure you get hold of the team that's actually looking after you at the hospital and have a chat with them, let them know what's going on so that they can give you the best advice and make sure that you get the best care going forward, so that this actually isn't something that ruins your life going forward, because not eating and being in that much pain is just all consuming.
Well, that's quite a state to be in, isn't it? I mean, that's a serious state. Yes.
Yep. Yeah.
Okay.
Yeah.
Causes for immediate action. Yeah. Yep. Okay.
Yep.
Is there anyone else got any questions they'd like to ask? I know thank you everybody that's been dropping comments into the chat box. It's really much appreciated. But has anyone else got any comments? We're pretty much for time. Please, if you do, just hold your spacebar down or unmute yourself, and we've probably got time for one more question. No. So if we haven't answered someone's question, or you think of something, like I've said, just send it through to Look Good, Feel Better, or of course Victoria's put her email up there for us. So I'm going to close off now. And thank you, Victoria, so much. Really, really appreciate it. Fascinating subject. And I know 1 hour isn't long enough to do it justice, but you certainly did it justice. And so everybody that's on tonight, I'm sure are very thankful for the information you provided tonight. So thank you so much. We hope that everyone that's joined us has got some value for you tonight, because remember, it was about you. And thank you for choosing to join in with us. We really work hard to have people experience like Victoria to be able to share and help amongst our community, that's for sure.